Uh, okay. Good morning. Today we will have a ward round scenario discussion. We will today basically discuss on upper GI hemorrhage management. Dr. Milind Alokji is a third-year junior resident at MR Bangur Hospital will present, and Professor Sanjay Mohan Bhattacharya, who is Professor and Head of Surgery at Vivekananda Institute of Medical Sciences and RKM Shayapudistan, will moderate the session today. I will be there. So, Milind, you can share the scenario and wait for our discussion.
Yes.
Yeah, just read.
Okay.
A 48-year gentleman comes to the emergency with complaints of hematemesis since 4 hours and a history of melena. On examination, blood pressure is 90 by 60 millimeters of mercury and pulse is 102 per minute. How will you proceed?
Okay. So it is an emergency. Milind, you are an emergency medical officer. So here, you see the patient complains of hematemesis since 4 years only. Okay.
4 hours.
It's 4 hours.
And
Yes.
yeah, 4 hours. Sorry, 4 hours. And the BP is 90 by 60 and pulse rate is 102. What do you think of?
Sir, in my view, sir, this patient is having active bleeding, sir, and that is leading to an early features of shock, sir.
Okay. Okay. So how generally, what are the steps we can proceed to manage a patient of the GI bleed, upper GI bleed? What are the things you should keep in your mind?
So the first thing, as soon as the patient comes, and especially if the patient comes with an active bleeding, the first thing that we have to do is we have to secure.
It's not only active bleeding. Try to understand. Small amount of active bleeding will not cause shock. If you have shock, that means the patient is having a massive bleed which resulted in shock. Active bleeding may be it may be very small active bleed.
Yes.
So the term here should be patient is having gross hemorrhage.
Gross hemorrhage. So the first thing that we will, since the patient is having hematemesis, the first thing that we would like to do is secure the airway and the breathing, sir. We would like to ensure that the oral tract of the patient is clear and that the bleeding is not causing any kind of disturbance with his airway and respiration.
ABC
yes,
first.
sir.
Yes.
First airway and breathing, sir. At the same time, we will simultaneously collect the patient to all the features of the monitoring that we have, such as the blood pressure and the urine output, which will initially help us to see the amount of hemorrhage that the patient has had or the amount of how hemodynamically stable or unstable the patient is, sir.
Okay. Okay. Then. So you have already cannulated as because the 90 by 60, so you have a channel or access, vascular access is there.
Yes,
so you can start as because it is the 90 by 60 as because in acute bleed, so patient can have and pulse rate is 102. So you have the vascular access, you have started. So what fluid you will start initially?
Sir, we would like to start
and
with
side by side, what are the things you are supposed to do?
So we would like to start with I would like to start with crystalloid, sir, preferably Ringer's lactate. As it is the preferred in case of massive hemorrhage, it is the preferred crystalloid of choice. So I would like to in the initial phase, I would like to give a 500 ml bolus and like to see whether this patient is a responder or a not responder. So if there is a response to the fluid challenge, then I would like to continue with fluid resuscitation.
Okay.
And I will aim to hemodynamically stabilize the patient, sir.
Okay. So initially, after giving the bolus dose, you have seen the patient is responding well. But after 1 hour, whenever you are following the patient, you see this suddenly, again, the BP has come down. What you will think of?
So that means that the cause of the hemorrhage it has not So the cause of the hemorrhage, the active hemorrhage is still continuing. So that means
Milind, this patient is
Specific.
grouped as transient responder.
transient responders.
So that indicates that patient has continuing active bleeding.
Active bleeding.
Active bleeding. So then how we will proceed? The patient is having the active bleeding.
Sir, in this case, sir,
so do you want to take any history from the
Yes, sir.
patient or the patient party? As because you shall have to check the patient whether he is conscious or unconscious. So you shall have to take the history. If
Yes,
the
sir.
patient, as because patient responded initially, you want to do something at
Yes,
least
sir.
from the history. What history do you want to know from him?
And Dr. Bhattacharya, as Dr.
Please.
Bhattacharya asked you the general question at the beginning, what are the steps you follow for managing such patient?
Yes.
Your answer should be, sir, I will resuscitate.
Guys.
First is resuscitation. Second is taking a history and doing some lab assessment to come to diagnosis. And number 3 is to plan a definitive treatment. So these are the
Treatment.
3 basic steps.
3 basics, yes.
Okay.
3
So,
basics.
resuscitation, one is in shock. The first thing is resuscitation. Second is evaluation of the patient. Evaluation by history and examination and some lab parameters. And then consider, most important is consider endoscopy. There are a lot of discussion on that, what
Yes, sir.
time you do endoscopy, and then plan a definite treatment based on the diagnosis you could achieve based on this. And again, the treatment will be again a conservative, endoscopic, intervention
Surgical.
radiology, or surgical.
Surgical.
Okay,
Yes.
so this is the, if you are asked a general question, you just point out that my steps will be this,
Okay, sir.
and then go for each of these step, what you do,
Okay,
as you discuss your resuscitation. And now
Yeah, it
Dr.
will be
Bhattacharya has
very-
given a scenario that patient has got, this is a patient who is transient responder. That
Yes.
means this patient is being continuing bleed. So
Continue.
what to do in this particular situation?
So the first step was, so as sir had mentioned, was resuscitation. We have done, sir.
Yes,
We would then
that is
Yeah,
continuing.
we have
history,
done.
the
That is
history, and we
continuing.
will, sir, we will then we'll try to ascertain the cause of this bleeding, sir. So we would like to find out we'll take history, physically examine, and would like to send some
Okay,
basic lab
at this stage, in a 48 years old gentleman, what do you think is
What do
a
you think?
likely cause of this
Cause.
bleed? 48-year gentleman, you have not given anything, he is alcoholic or not, nothing is given. So what do you think is if you go with a usual presentation,
Sir,
what is the likely
Gradually we
cause?
give you clue. What are the
Sir,
T cells?
Sir, in a middle-aged man, sir, in a middle-aged gentleman, sir, it can be most commonly due to a peptic ulcer disease, sir, as a
Yes.
complication
So
of a peptic
peptic ulcer
ulcer.
bleed is the most common. Yes.
Number
Next.
1, peptic ulcer disease.
Next.
Anything you want to know?
Sir, I would like to ask the patient for a history of intermittent attacks of pain abdomen, sir. Whether patient has had a history of
So along with that,
Peptic
so
ulcer.
you should keep in your mind, you
Yes,
should
okay.
take the drug history.
NSAID
Whether
use.
the patient is having any bleeding disorder. Okay, so you shall have to think of in that way, then it will be clear for you. If
Sir,
the patient doesn't have any history of drug intake, so suppose the patient is getting 48 years hypertensive, physician he has advised him to take the aspirin. So
Yes, sir.
whether that aspirin is the cause,
Yes,
so
sir.
you don't know. So you shall have to take the history from the patient of his drug history, family history. Family history, what family history? 48 years, you know, the upper GI hemorrhage can happen, very rare, though it is rare. Familial polyposis or something
Polyposis,
is
yes.
there. Yes, so you shall have to ask the few questions. So proceed, please. What
Sir,
are the things
I would
you
like
ask?
to,
So
sir,
you
in
said peptic
patients,
ulcer is the first cause. Next common
First
cause
cause.
is?
Next
Next
common
common
cause.
cause is?
sir, next common cause will be, sir, esophagitis or gastritis, sir.
No, before
Yeah.
that, I think
Before
it should go group as variceal bleed.
Sir,
Varicose
sir,
bleed.
there are causes are non-variceal bleeding and variceal bleeding,
Yeah.
sir. Most
Very good.
commonly being non-variceal bleeding.
Yeah.
Among non-variceal bleeding, gastric and duodenal ulcer being most common,
Yeah.
followed by gastritis and esophagitis. And sir, among variceal bleeding, most common cause would be due to
The other
No,
cause,
no.
if you say non-variceal,
Other
there are
cause.
some other causes like mallory
Some other cause.
Mallory
Some
syndrome.
other cause.
syndrome, then
What is
drug-induced.
Drug
Okay,
induced such as
drug-induced.
NSAIDs, sir, and if the patient is on anticoagulants,
Yeah,
sir.
yeah.
Okay.
So
What is
the-
Mallory syndrome?
Sir, Mallory-Weiss syndrome is sir, it's a
So one clue
sudden
will be there.
longitude. Sir, sudden
One-
longitudinal tear, mucosal tear in the esophagus following a bout of vomiting,
Or
Yes.
vigorous vomiting,
vomiting or retching.
retching.
or retching. So besides this, occasionally there might be the bleeding. Suddenly there is a profuse hemorrhage, followed by, you can't see in the endoscopy initially anything, as because we are not keeping it in my mind, as because some Dulophous disease, arteriovenous malformation might be there in the submucous
Yes, sir.
area.
Yes, sir.
So you should keep in your mind also that that is generally in the fundic part, near the
Fundic
fundic part body, or it can be anywhere in the stomach.
Okay.
So what else? So you have divided the variceal and the non-variceal bleeding. Okay. And very occasionally familial diseases, and whether it is drug induced or not. So if you have all these features, then how to proceed? When
Uh,
you are as
What are
because
the
patient has-
pointers? What are the pointers to variceal bleed? You said variceal bleed is another important group.
Yes,
So
sir.
in the history and examination, what do you expect to find that yes, it can be a suspected variceal bleed?
Sir, in case of a variceal bleed, we would look for
that is physical examination, what you
yes,
will
sir.
get.
Sir,
Or
we
history
would,
event. History event.
And
sir,
Patient
in
might
history,
be alcoholic.
sir, yes, a patient will be a chronic alcoholic, sir. He would have had earlier episodes of severe pain abdomen, might have had previous episodes of gastritis, pancreatitis. Sir, in examination, we would like to
Cirrhosis
No,
patient
this-
is pancreas.
Cirrhosis.
Cirrhosis
Yes.
patient might
This
have
is
previous
very rare.
bleed. The
Yes, sir.
important history is whether the patient has previous bleed or not.
minus previous bleeds. Yes.
Yeah.
As
And
because
sir, in examination, we would like to look for the stigmata of liver
Yeah.
disease, sir.
yes,
Such
what
as, sir,
else?
we would like to look for if the patient has icterus, sir, patient has parotid swelling, patient has spider nevi, gynecomastia, Dupuytren's contracture, so
Okay, ascites.
Okay,
ascites,
besides
yes,
this,
ascites,
ascites,
jaundice,
abdominal examination, ascites you might get.
and jaundice.
ascites,
also.
yes.
You see, the most of the cases of the cirrhosis of the liver, only the 30% of the cases develops the variceal bleed. Okay, not all the patient. And the variceal bleed, it will start immediately and it is massive. And
Yes, sir.
if you resuscitate, the chance of bleed is very high. So
Yes,
you
sir.
should keep in your mind. So that's why whenever the patient is responding initially and after that again bouts, so you should keep in your mind the possibility, what else? Okay, then what you will do next?
So, if once we have taken the history and the examination, we'd like to also send for some
There is
basic blood
no
investigation.
cirrhosis of liver, no variceal bleeding. You are thinking from the history. So what we will do next?
Sir, we would like to send some basic blood investigations for the patient, sir, and we would like to go in for early endoscopy, sir.
No, before endoscopy, do you want to do anything? Blood
You
parameter.
said you should do blood.
Yes, sir.
What
Blood
blood
parameter?
parameter will alarm you? I mean, you had a CBC, hemoglobin and CBC.
Yes, sir.
So what is the alarm in this?
Sir, if the patient is in case of complete blood count, sir, if the patient is anemic, sir, and so the patient
What?
also has a history of
What
melena.
what level of anemia will alert you? What is the guideline now?
So less than 7
Yes.
milligram per dl, sir.
So it is now said that you are alerted and you need to consider urgent transfusion if the hemoglobin drops. Some people say 8, but 7 is
Less than 7, sir.
7 is accepted. So hemogram is important.
Yes, sir.
And
So, Milind,
Yes,
think of one thing as because the hemoglobin hemoconcentration might be there, as because this patient of hematemesis of 4 hours
Yeah.
duration. Okay, so
Yes,
you
sir.
might not get, you might get the hemoglobin 10 as well. So it is occasionally conflicting your decision
So,
that it is hemoglobin. Clinically, you are thinking the hemoglobin is less, but lab report has come 10. So
the
you should
packed cell volume
Yes,
we would try to keep it above
Yes.
30%, sir.
Yes. So that one will give you and one more guide. Okay.
Yes.
What else? Occasionally, if the patient comes to you not after 4 hours, if patient comes with upper GI bleeding and it comes to you, patient comes to you after 12 hours, is there anything you are supposed to look for? As because you know the blood is digested by the acid and it will
Yes,
go
sir. Melina,
down.
sir.
What other
Melina,
parameters will go up?
other blood parameters are
Sir,
important.
stool for occult.
No. What do you need occult blood?
No, sir.
Patient is bleeding,
Frank
cross
bleeding.
bleeding. Don't need occult blood.
Always
You look
urinary
for blood urea
nitrogen.
nitrogen.
Blood urea, sir. So blood urea nitrogen to creatinine ratio is an indicator of a GI.
Yes.
Sir, yes.
Okay. And
Yes, sir.
occasionally we are supposed to send the albumin as well.
Yes.
Okay. As because some scoring systems are there. How do you want to score a patient in upper GI bleeding?
Sir, in upper GI bleeding, sir.
Any scoring system?
Yes, sir.
Easy,
Sir, we have
easiest scoring system. Easiest scoring system.
Sir, Blackford score, sir.
Okay.
Sir,
Glasgow
score.
Glasgow, Batchford, Rockall.
Rockall score.
There is another very that Dr. Hodja says AIM.
AIM
and
65.
Yeah.
65. AIM 65 means that here it indicates age of the patient is above. Yes. What it signifies? This scoring, why? Why we are thinking this scoring? To prognosticate the patient. As because if you see the age of the patient is above 65 or 70, so what will be there? The chance of rebleed is very high.
Yes, sir.
And so you shall have to intervene as because the chance of rebleed is very high. Okay.
Yes.
So and the prognosis as a whole. As a whole, the prognosis. If you have a patient with low albumin, international normalized ratio is more than 2.5.
Yes.
Okay. Mental status is mental patient is confused and the age is more than 65. These are the parameters which suggest that patient is a high risk patient. This patient needs early endoscopy. This patient needs early intervention. Okay.
So that besides is these comorbidities, you should keep in your mind. What are the comorbidities? Why? Suppose the patient is having myocardial ischemia or the myocardial infarction had any history. So in that case, what we were discussing, the hemoglobin level, if it comes 7, then in that case, if you keep the hemoglobin level 7, so there is chance of more ischemia. So you shall have to keep, instead of 7, it should be a bit more or above. Okay. That is near to in and around the 9. Okay. If the comorbidity is like.
Yeah. And another thing is, if the patient has a cardiac or pulmonary disease, you should be cautious while resuscitating the patient.
Resuscitating the patient.
You cannot overload this patient. They are the patient who may have failure if you do overzealous fluid administration.
Infusion, then patient might develop heart failure. Okay. So these are the things so you should consider while you are treating a patient with upper GI bleed. Okay.
Yes, sir.
Okay. Then you have stabilized the patient. So you have given the IV fluid, crystalloid. So then what to do? Patient has stabilized. BP is normal now, 100/60, and pulse has come down to 90. And what is the next step?
Sir, now we would like to localize the site of the bleeding, sir.
Yes. How to localize?
Sir, the preferred way would be to, the history and the examination would give us an indication, but the preferred way would be to go for an upper GI endoscopy, sir.
Before upper GI endoscopy, Milind, what is the status for putting a nasogastric tube? We are always tempted to put a nasogastric tube. What is the recommendation for putting nasogastric tube in these patients? You see, this patient has got hematemesis. There's no doubt that is upper GI hemorrhage.
Yes, sir.
So there has been a lot of controversies regarding the placement of nasogastric tube. You see, some people say that nasogastric tube is not routinely required. It can be required if you need to have a diagnosis whether it is upper GI hemorrhage or not. Second is, patient has a lot of clots in the stomach and upper GI endoscopy is not possible. So in that case, you can put a nasogastric tube because nasogastric tube in no way is a part of therapy because getting gastric lavage may not control the bleed.
Yes, sir.
Okay. So that's why whenever the patient has come to you with upper GI bleeding, then it's okay. It is very rarely needed to put the Ryle's tube. But if the patient comes with the melena with shock, in that case, it is mandatory to put an Ryle's tube and to check whether it is the bile or the
Bile
blood.
or bleeding, sir.
Yes.
Yeah.
Then you can assess the which way you will proceed.
Yes,
Okay.
sir. Yes, sir.
Okay.
Fine.
Then.
So it's an endoscopy. Again, this is the most important part of management. So what is the recommendation for doing endoscopy early?
When to do endoscopy?
Intermediate or delayed?
Sir,
That is, sir is asking whether it is within the 12 hours or 12 to 24 hours or after 24 hours.
Sir, early endoscopy, mostly it has been seen that within 24 hours is most beneficial. And if the patient is stable, then we should go for endoscopy within the first 12 hours, sir.
Okay. So
if
normally,
patient is stable, no, you are saying reverse way. If the patient is stable, you can wait.
Yes, the patient is stable. Especially for active bleeding, we must go for endoscopy.
So
as soon
patient
as
is unstable, you are resuscitating the patient, you cannot maintain the patient. There comes a need for urgent endoscopy to localize and do some therapeutic intervention. Okay, if the patient is resuscitated well,
endoscopy.
If the patient is resuscitated well with your 501 liter of fluid, so patient is now maintained.
Yes.
In that case, you can delay the endoscopy beyond 12 hours also.
Yes. It has been shown that the early endoscopy before 24 hours does not differ in the early outcome of the patient's management.
And in fact, more patients die who are having early endoscopy because they are the patients who are more critically ill. They are more bleed.
Okay.
So you are doing endoscopy. What are the things you look for in endoscopy? This is important.
Sir, firstly, sir, in the endoscopy, sir, we would like, we would like to most importantly localize the site from where the bleeding is.
It's an ulcer. It's an ulcer. It's an ulcer which has probably bled.
Yes.
So what do you see in the ulcer? First, an ulcer, peptic ulcer, which is bled. What do you see on endoscopy, and what measures you can take to control?
So that's why one classification is there. If you know that one classification, that will give you a guide.
Sir, we use the forest classification, sir, which will tell us whether
so you find there is a Sparta there.
Yes, sir.
Forest 1A.
What to do?
Sir, in that case, sir, we can, sir, since we are doing the endoscopy, it can be used as a therapeutic modality also. Sir, we have various options such as we can use an electrosurgical device to cauterize the bleeder. We can use a clip or a band to ligate the bleeder as well, sir.
Or you can sometimes inject.
Inject epinephrine.
You can inject
diluted epinephrine.
Or glue. Or glue.
Okay, so that's why if it parts, then you can give the clip, or if it doesn't parts, it is actively bleeding. So initially we'll start with what sir is asking. With the adrenaline injection, we can check whether bleed. Most of the cases with an adrenaline, it comes down 10 ml maximum, it comes down. So how adrenaline acts or how this injection reduces the bleeding?
Sir, adrenaline is a local vasoconstrictor, sir.
And turgidity, as because you are giving it submucosal, so it will give in the pressure. So that pressure is initially. Okay.
Yes, sir.
Okay.
So what else you can see in a peptic ulcer apart from SPART?
Sir, sir, we can also, sir, we can see an active vessel, but it is not bleeding, sir.
It's a bare vessel.
Bare vessel, sir.
Bare vessel, not bleeding.
Not bleeding. We can see a healed ulcer, sir, but with
not healed ulcer. No, he's bleeding. You can't see healed ulcer.
He's bleeding.
You can see a vessel. You can see a what? Clot.
Clot, yes, sir.
Over the bleeding vessel. So if the clot is there, what do you want to do?
Sir, in that case also, we would like to, secure the vessel, sir.
No.
There is a controversy. Some says that remove the clot and then check whether there is an active bleeding or not. Some says if clot is there, if there is no blood within the stomach, you can wait. Don't dislodge, as because the clot is there, so it will, when a bleed will stop by itself.
And these are the patients who have more incidence of recurrent bleed. If you have a clot, this grade indicate that patient might bleed again. So you should be cautious.
So besides this, what else? Besides that, you can see the recent signs of hemorrhage. What are the recent signs of hemorrhage? Stigmata of hemorrhage. That is black spot on the mucosa. Okay.
Sir. Yes, sir.
Black spot on the mucosa, recent side of the hemorrhage, you can see there, that will signify this, yes, there was bleeding. So, okay, endoscopy, you have seen there is no ulcer. Then what you are thinking, there are diseases are there. What you say is the two things. If the patient is alcoholic retching, then you can see, you shall have to make the J, and you can see, number one, there is a tear, longitudinal tear.
Yes,
Or if it is Mallory-West syndrome, then you will see. But if it is Dulofeu's disease, so
Yes,
you
sir.
shall have to make the J, as because you can't see, as because
Yes,
it
in
is
the
the fundus of the
fundus
stomach.
region. Yes, sir.
On the dependency, it has come down. So you have
Yes, sir.
sucked out the blood, so you can't see anything.
Yes, sir.
Then directly don't come out. Then we shall have to check whether make it J and
J.
check in
The
the
fundus region, sir.
fundic area whether there is a bleeding or not.
Yes, sir.
Okay.
Yes,
So
sir.
this is the stomach. You have seen nothing is there in the stomach. It is coming out from the duodenum. So what you can do else? So rare causes are there. You have discussed about the familial disease is there, polyp is there, one malignancy can be there. So
Malignancy,
we
yes,
shall
sir.
have to keep in our minds that these are the things we should keep. And very rarely, though they are not coming with the massive bleed, but occasionally upper GI bleeding can associate with the Zollinger-Ellison syndrome. Okay, you should keep in your mind. If you don't put the scope beyond the first part of the duodenum, then you might not get the multiple ulcers.
Yes, sir.
Okay, so these are the things you must follow the patient. Suppose you have seen it is not an ulcer, it is an esophageal varix. So what you can do?
Sir, in case of an esophageal varix, sir, if you are already
Patient is
doing
stable. Patient is stable.
patient stable. Sir, since we are already doing endoscopy, sir, we would like to, sir, we would like to identify the esophageal varix and secure it with the clip or with sclerotherapy, sir.
Okay. Okay.
What
Then
all can be done? Is
what
bleeding.
else?
Is bleeding. One is injection. Second is,
sir, the injections are clipping.
clipping is next part.
Next.
Injection,
Not
next
clipping
will
is
be-
initially.
next will be
Banding is
argon plasma coagulation.
what? Argon plasma coagulation.
Okay,
Yes.
banding. Before
Banding.
clipping, you
Banding.
want to make say banding.
Yes, sir.
Okay.
So Dulofeu's disease, again argon plasma. If
Argon
there is no bleeding, just superficial ulcer, if you have the facilities, then you can do that. Okay.
Yes,
So
sir.
these are the things you can do. So suppose the variceal bleed, patient is, you have seen the endoscopy done, variceal bleed, then what are the things you should keep in your mind? The patient can
So rebleeding, the risk of rebleeding.
rebleed. Suppose that patient is hemodynamic unstable, and you have seen the initial endoscopy, you have seen that this is the variceal bleeding. Then what else you can do besides the clipping? So you are not expert enough, so you can't put any injection, or you can't have the facilities for banding. What you should keep in your mind, the patient again start bleeding and patient is gradually becoming unstable. What you can do else?
So there are
Before
medical.
that, Milind, before that
Okay,
is an
okay.
endoscopy intervention. Now, clinically, if you suspect it's a variceal bleed,
Yes, sir.
there are some more measures you take before you take the patient for endoscopy intervention even. What are the
So
things?
that's why
Apart
that
from
is I'm asking. That
Yeah.
was
Yeah.
I am as because
there
the
are-
patient suppose
with
you have seen
resuscitation,
it,
what else you give, and some of the variceal bleed patient respond to these measures.
and
Sir,
what is that measure?
we can start with medical intervention. So we can give the patient octreotide or
Yes.
vasopressin. Firstly, sir.
Okay.
So secondly, if it is an active bleeding and we are sure that we are not able to secure it or reduce it, then we can, sir, go for a Sensitikin Blakemore tube, sir.
Yes. So if you, what is the problem with the vasopressin? If you give the vasopressin,
Sir, vasopressin causes cardiac instability, sir. So octreotide.
cardiac and the constriction, splanchnic vessel
Splanchnic
constriction.
constriction. Splanchnic vessel
So
constriction.
you shall have to give some nitroglycerin. Otherwise, if the patient is elderly, then there is the possibility of acute myocardial infarction. So nowadays, instead of vasopressin, so we can use
Octreotide.
octreotide.
Yes.
So you should keep in your mind before diagnosis what is, whether it is an ulcer or it is a portal hypertension. Initially, we should keep in our mind, we should start whenever this patient is coming to us one bolus dose of PPI.
Yes, sir.
This is mandatory.
Yes, sir.
So we are not sure it is variceal bleed or it is an ulcer. But benefit of doubt, 80 milligram, we should start immediately IV bolus followed by either in bolus doses or in infusion pump or
Yes, sir.
8 hours interval.
Okay, sir.
Okay.
Yes, sir.
So you see, you cannot take a unstable patient to endoscopic suite. That is one thing you should keep in mind. Basically you have to do resuscitation, give the patient some somatostatin analogs, give the patient PPI, and then if not being controlled, you can try with Sengstaken tube, and patient should be relatively resuscitated before shifting to endoscopic suite. Because endoscopy patient is for diagnosis and for some therapeutic intervention. A unstable patient will not withstand this endoscopic stress.
Yes, sir.
Okay, what is the problem of the Sengstaken? Have you seen the Sengstaken tube?
So I've seen pictures. I've not seen it physically.
Okay, sir. Okay. Nowadays it is, I think it is not available, or if it is available, so what are how many balloons are there?
So there are 2 balloons, sir.
Okay.
So there are 2 balloons and 3 tubes, sir. 3 entry portals. The balloon at the top is the esophageal balloon. Then we have the gastric balloon, and then beyond the gastric balloon, we have a channel that is used for suctioning the contents or the blood that is collected or the clots that are there in the stomach. So initially we inflate the gastric balloon and we try to see if that pressure is able to reduce the hemorrhage. And if that does not stop the hemorrhage, then we inflate the esophageal balloon, which further applies the pressure. And the gastric balloon also helps to keep the tube in place. And we can use the middle tubes to suction the whatever the collected contents of the bleeding that is there in the stomach.
Okay. So besides that, what precaution you should keep when we are putting an Sengstaken tube, which is having the 3 channels?
So that
what is the precaution? As because you are giving the lower esophagus, in the balloon in the lower esophagus, and the balloon in the stomach. Okay, yes, and another channel is for the suction.
Yes.
So these are the 3 channels. So what is the problem you can face?
Sir, the positioning has to be proper, sir. Otherwise, the gastric balloon.
No. That's not the positioning. Problem is there is secretion from the upper esophagus. If it is the prolonged period, the patient can aspirate the secretion from the upper esophagus. So nowadays it is available with the 4 lumen having the esophageal section for 1, or if it is not there, so we shall have to tie in 1 Ryle's tube proximal to the esophageal balloon. You understand?
Yes, sir.
So that we can suck out the secretions which is above the esophageal balloon. Otherwise, patient if the unconscious, so he will aspirate, ultimately he may die, or there might create problem, pneumonia. Okay.
Yes,
to prevent that, so we shall have to. So if you think of it is a variceal bleed, so initially we should keep in our mind the prolonged hospitalization will be there, the chance of infection will be there. So to prevent that, if you think of it is the variceal bleed, so we shall have to start 1 antibiotic as well. So we should keep in our mind these points. Okay.
Yes.
Now uncontrolled endoscopic intervention and patient is still bleeding. What next?
What to do?
Understand? Endoscopy has tried with injection.
Yes, sir.
And patient was relatively resuscitated, but again patient has a bleed and patient is again deteriorating.
So you have diagnosed, you shall have to divide in the 2 ways.
Yes,
if the ulcer is there, it is bleeding. If no ulcer, only it is the varix, then so you shall have to divide in the two groups. Okay.
Yes, sir.
The
Sir,
major head.
in case
Yeah.
of a peptic ulcer disease, sir, we if the bleeding is not controlled, we generally try to follow conservative management again and give a retrial for endoscopy. And even if that fails, then we go for surgical intervention. In case of
Okay,
variceal bleeding,
so
sir,
how many attempts? So 2 attempts can be
attempts.
done. Yes. So we should keep in our mind the 2 attempts we should try endoscopically. If it fails in after 2 attempts also, then we will go for the surgery.
No, actually now the interventional radiologists are more conversant, and again they are also competent to embolize even the vessel supplying the ulcer bed also. So
That
if you have the
is known as
facility,
the super selective embolization.
if you
As
have the
because
facility,
previous-
if
Yeah.
you have the facility, one should try for doing a CT angio, localize the bleeding, and if possible, do a procedure by interventional radiologist. If the facility is not there, you will to go for surgery. What do in surgery? Suppose you have a bleed in the duodenal ulcer, which is actively bleeding, and you have explored the patient. What are you going to do?
Sir, in that case, sir, first of all, once we do a duodenotomy in the first part of the duodenum, and we explore with the vessel that is bleeding. Mostly, it is the
No.
in case
Only
of a duodenal ulcer.
duodenectomy is not possible. If you say that duodenectomy, it is not possible. The space won't give as because the bleeding is from the first part of the duodenum. So you shall have to check gastroduodenectomy.
Yes,
Duodenectomy.
pylorus in the duodenum.
Yes,
Sir. And
yes.
so
Because if you do duodenectomy,
Yes,
the
sir.
duodenum will tear more, then you might be in trouble. Okay, you can't see.
So you pain and you find there is a spot in the ulcer bed. What are you going to do?
So we secure it with so we secure it with the stitch of 8, sir.
Okay, fine. You have,
yes, sir.
you have sutured.
Yes, sir.
Is over, or you need to add something else? That's what I'm
Suppose
asking.
it is an ulcer. You have seen it is an ulcer.
It's an ulcer. Ulcer which is bleeding.
Keeping in your mind,
You have
keeping in your
overrun
mind,
the
it is
vessel.
an ulcer.
Yes, sir.
What else you need to do? Is your job over and come out
No,
after
sir.
underrunning the vessel?
No, sir. We would. So if it's an ulcer, we have to take a biopsy.
Biopsy from
Biopsy.
duodenal ulcer? No.
Sir,
If
You have opened the patient. Patient has got an ulcer which is bleeding. So you should add a procedure which will allow
Sir,
healing of this ulcer.
sir, truncal vagotomy, sir.
No. Before that, you shall have to ask the sir in 2 ways. Sir, if it is the duodenal ulcer, then we should think of it is acid secreting. So we should keep in our mind to reduce the secretion. So can we do the vagotomy, truncal vagotomy, if the patient condition permits? Okay.
Yes,
so
sir.
you shall have to tell in that way. Otherwise, if it is in the, we can see it is not in the duodenum, it is in the stomach. Okay, then we shall have to do whatever you said. You shall have to take a biopsy from the margin, or you will take a piece of tissue from the margin, and then you will suture. As because the most of the cases in the stomach ulcer, they are the malignant. So if you can't justify in that way, the sir won't satisfy.
Okay, sir.
You shall have to say in that way.
Okay, sir.
I think Makhanda, it is your
If
answer.
it's a duodenal ulcer, we assume this is a benign. And you should take some measures to treat the ulcer in the same way.
Yes, sir.
And besides that vagotomy, how you close the duodenum? Now, as because you have done the pyloromyelitis, that is the gastroduodenotomy, how to close that area?
Sir,
I think you have not. So that's why it can be a problem for you. But
sir, we close it. No, sir, we close it if we make a longitudinal incision to open it, and we close it in a transverse direction, sir.
So it becomes a pyloroplasty. So if the area is healthy, you see, most of the time in a chronic ulcer, this area may be scarred. This may not be healthy even. In that case, difficult to do a pyloroplasty. If this area is clean and you can do, say, pyloroplasty, you can do a pyloroplasty. That is an adjunct procedure for a truncal vagotomy.
Yes.
Milind, I will give you one clue. It is very, nowadays, nobody is doing all these things. The previously we used to do. After exploration of the abdomen, how we will think of there is an ulcer is there in the duodenum or not. So we shall have to take one piece of gauze and soaked gauze, that is, we used to normal saline soaked gauze, and we want to give on the few patients or rub the mucoduodenal serosa. What happened? If you see the petechiae, that is an indication of some ulcer. Makonda, apnara korechen kina, I don't know.
Yes. We have done.
But previously
These
we
are
used
for
to
chronic
do,
ulcer. We are for chronic ulcer.
this is
we are
for
doing
chronic
electric
ulcer. This is for chronic ulcer. Okay.
Yes, sir.
Okay.
Okay. Now it's
Next, we
varicose
have,
bleed.
yes.
Varicose
Now
bleed
we have
not
seen
controlled by
varicose bleed,
endoscopy.
not controlled by endoscopy.
What should be the next?
Sir, we can go for TIPS procedure.
Sengstaken tube, you have given the Sengstaken tube, you have given, you have tried for 12 hours, but even then it is bleeding. Then another scenario, or one scenario, you have checked it, so you have given either a sclerosing agent you have given, or you have banded, but even then it is not controlling, so you have started then Sengstaken tube. But Sengstaken tube, even after putting, the bleeding is persisting. Then what you want to do?
Sir, we can then go for a shunting procedure, sir. Preferably the
Shunting?
TIPS
No,
procedure.
no. Don't go for shunting procedure. So many things are
TIPS.
there before that.
Sir,
Hello?
stent, sir, we can put in a stent.
Stent. What stent? So no, as because you know it is an esophageal varix. So what are the site of the varixes you know? So
Yes,
what
sir.
are the communications you know?
Yes, sir.
Huh?
Yes, sir.
So you what you know there it is a communication at the gastroesophageal junction. So what
Yes,
are the vessels are there?
So
I think Dr. Bhattacharya, now the recommendation is what we are discussing is esophageal devascularization. That is a
Yes.
life-saving procedure, but
Yes.
But if the facility is there, the recommended treatment for this uncontrolled bleeding will be going for a TIPS,
No,
transjugular.
sir. Yes. Sir. If it is available, sir,
Yeah.
it should be available. If the center which doesn't have any that facilities, then yes. What
you
is
cannot
TIPS?
take this patient for operative shunt in emergency setting. Very
No
high
shunt.
mortality.
No shunt,
This will be TIPS.
devascularization.
This will be portosystemic shunt by transjugular route.
Yes,
if it is available, you do that. Suppose you don't have the facility and patient is bleeding too much. What is that procedure called as? We have saved number of patients by doing the procedure.
Sir, devascularization.
What is that operation called as? That is Sugiura technique.
Sugiura technique.
Okay.
Yes,
Sugiura technique, where you do a esophagogastric devascularization.
Okay, sir. Yes, sir.
Okay. And with or without splenectomy. Okay, that is the emergency procedure.
Okay, sir.
Now a lot of patients are on antithrombotic drugs, aspirins. So if you have the history being taken and you find the patient is taking these antithrombotic drugs, antiplatelet drugs, what is the strategy now? Patient has come to upper GI hemorrhage.
Sir, we stabilize the patient and we give the particular the specific antagonist to whichever anticoagulant.
No. You have to now review why was the patient put on this drug. Try to understand. Patient who has got a heart valve has to have these drugs. Patient who is taking these drugs just for a history of hypertension or possibly ischemic heart disease can go easily off from these drugs. Okay, you have to always weigh the indication for which the drugs were started.
Okay.
Milind, so
Yes,
we
sir.
shall have to divide in two ways. Okay. So there is no contraindication of doing the reducing the dose. Occasionally, you will see some physicians are prescribing the 75 milligram of the aspirin.
Yes, sir.
Some physicians are giving 150 milligram of aspirin. But in both the upper and the lower GI bleeding, if you see that it is torrential, you can stop it for the 3 to 5 days and they restart in lower doses. Okay. So you can come down from 150 milligram to 75 milligram.
Yes, sir.
Okay. So there is no contraindication of giving 75 milligram of the aspirin in that group of the patient where they are having the comorbidities, otherwise they will die or there will be any problem.
Okay, sir.
Okay.
So one scenario is
one
patient
thing.
is on warfarin
Yes, sir.
and patient is now
patient
bleeding, possibly
Yeah.
because the PT-INR has gone more than 2.5, it's at the point of 3.5. How can you treat this patient who are on overdose of warfarin? What is the treatment schedule?
So, sir, we start the patient on vitamin K, sir.
Give one dose of vitamin K, but he's still bleeding. What else to nullify the effect of this warfarin? Now you have these drugs are now available in the market now. Have you heard of anything called PCC?
Yes.
Prothrombin concentrate complex. It is said that if you give 4 units of prothrombin concentrate complex, it reverses the effect of warfarin.
Okay.
Okay.
Yes,
and if it is not available, only vitamin K may not reverse the effect of warfarin immediately.
Yes.
It takes long time for this to get
At
reversed.
least 3 to 5 days time it is needed to reverse the effect of the warfarin.
So in that case, the alternative is to give the patient fresh
frozen plasma. Yes.
Okay. So the first thing to give is PCC, 4 units of PCC, and
then
fresh frozen plasma, or vitamin K has to be given. That's true.
Okay.
But to have the immediate effect, we have to have this drugs being available.
Okay.
So patient is on aspirin.
Yes.
What can revert the effect of aspirin? There is no antidote of aspirin. Okay, but you can treat this situation by giving the patient fresh frozen plasma.
Okay.
Okay, because you see, this is a situation where you have a platelet dysfunction.
Yes, sir.
Okay, and
yes,
in
sir.
some cases they say that if you give the patient platelet concentrate, they can revert this effect.
Actually, here platelet thrombocytopenia is not there. Thrombocyte is there, but their function is not. That's why we shall have to give platelet. And another thing, so we can stop that one as well. We can occasionally, we are doing, suppose occasionally we can do the low molecular weight heparin. Low molecular heparin 40 milligram, you can stop that one. And 1 day or 2 days, if the bleeding stops, then you can switch on to other drugs like the low dose of the aspirin. Okay.
Yes, sir.
So suppose, so okay, fine, that is there. So anything to cover in the pediatric age group, if it is there, so what else you have?
Sir, in pediatric age group,
better to not to go there, as because we are not the pediatric surgeon, I think.
yes. Basically, we can now summarize. If you summarize the situation that whenever such scenario is given, your job is to answer methodically.
Yes,
that in a scenario like this, first thing to do is resuscitation, and you have some components of resuscitation. And then after resuscitation,
Mahanta, 1 minute.
Yes.
Whenever you will require transfusion, what you should keep in your mind? Suppose patient requires 4 units, 5 units transfusion. So what are the proportion of component you are supposed to replace?
Sir, it should be given 1:1:1, sir.
Yes. So you should keep in your mind, because these are the tricky point occasionally examiners are asking. Okay, fine. Thank you.
Again, now you have a treatment called massive transfusion protocol. If the patient is bleeding too much, there is massive hemorrhage, you should not hydrate the patient by giving only crystalloid, which will cause dilution and coagulopathy.
Yes, sir.
So in that case, people have come with the idea of giving the patient massive transfusion protocol. Okay, what is the definition for massive transfusion in a scenario like this?
Massive transfusion is transfusion of more than 10 units in 24 hours or 10% of the patient's body weight.
Or 3 units in 1 hour.
3 units.
If you repeat 3 units of PRS in 1 hour or 10 units in 24 hours, we call that as a massive protocol. But if the patient is bleeding too much, a massive bleeding, in that case, if you have the facility, because you have to give a massive transfusion, you need to have good blood bank facility. So if the facility, instead of giving crystalloids, you can switch on to massive transfusion protocol. Okay.
Yes, sir.
Dr. Bhattacharya, anything to add? We have gone to the details of the discussion, starting with the resuscitation, history and evaluation, and then basic lab investigations, an endoscopic procedure, and then in situation where if the facility to go for therapeutic embolization, and ultimately the surgical treatment.
Yeah. I think more or less we have covered the entire scenario.
I would like resident put their query in the chat box so that we can, at the end, we can take up those questions in the chat box and discuss.
Okay.
Okay.
Okay. Thank you. Thank you.
Thank you. Thank you.
Thank you, sir.
Thank you, Milind.
Yeah.
Thank you,
Thank you.
Milind. Thank you, Makanda.
Yeah. Thank you.
Thank you,
Okay.
sir.
Thank you, Milind. Answered well. Thank you.
Thank you, sir.